I'm Drew Burleson. I'm an orthopedic surgeon at Beacon Orthopaedics. Absolutely astonished there's this many people here tonight. But I think I gave one of these pre-COVID on hip pain. I guess maybe knee pain and runners may be a more pertinent topic because the hip pain one there wasn't very many people there. But anyways, we want to kind of go over just a lot of stuff that we see. I mean, in regards to knee pain and runners, we have Alex, who's one of the physical therapists who works upstairs, who's going to help us kind of go through some of the therapy components of this, because a lot of the stuff that we see is non-operative in nature. I'll touch on that in a second, but just for those who don't know me, I have two kids. Sloan is up here with me on the left. This is Story. She's our newest. She turns a 1-year-old this weekend. This is Christmas. This was Halloween, I think the year before. I played basketball at Wright State. Prior to coming to Cincinnati, I did my training out in Los Angeles, where I was the assistant team physician with the Dodgers, the UFC football team, the Kings, and that was a lot of fun. It was the weather was a lot different there than it is here. This is me during fellowship. Let's see the next slide. Maybe. Oh, I have this fancy pointer that I thought was going to do great, but now everything froze. Oh boy. Oh, there we go. I got too impatient there. This is me operating with one of my mentors, Dr. Neil Alatrosh. If that name sounds familiar, he did the ACL surgery on Joe Burrow. He's also recently operated on Saquon Barkley this past year, Cody Bellinger. He's one of the guys who basically every professional sports athlete goes to. Now I'm one of the assistant team physicians for the Reds, and this is the last time we were able to have people, basically fans in the stands at spring training was a couple of years ago. So this is my wife and my daughter that came to spring training with us. But again, I'm a sports medicine surgeon, but it doesn't mean that basically, like if someone were to come see me, that you necessarily need surgery. Like, let's say about 80% of the patients that I see are non-operative patients, and a lot of the stuff we do physical therapy, injections, a lot of stuff that can be done prior to having surgery. We usually really try to leave surgery as a last resort for a lot of these issues. I don't know if this is going to play now, but I can't even think about running with. I was a big Friends fan, and this was an episode of Phoebe whenever she was running, but I'm now really worried that everything's going to freeze if I try to play this video. All right, so we'll skip that. So this is a very generic term, anterior knee pain. Okay, this is probably, I would say, one of the most common things that I see in clinic, especially with runners. I mean, I saw it probably 10 times today. Patients will come in really complaining of vague pain in the front part of the knee. Usually, it doesn't even necessarily need to be like a new activity that someone took place in, but they'll have a lot of pain going up and down stairs. They'll usually say that going down the stairs hurts worse than going up the stairs. Squatting can be painful. Lunging can be painful. Sitting down for long periods of time, then standing back up, so they'll say that driving is bothersome for them as well. And usually that means, like even from that story, I feel like I can hear my medical assistant who gets the history, and I can just be like, okay, this person's going to need physical therapy because they have some form of anterior knee pain, or Patella femoral syndrome, we call it. And again, anterior knee pain can be any number of a different types of pathology. So I mean, again, like if we're looking at the knee, you have the kneecap right here. Your quadriceps tendon attaches onto the top part of the kneecap, so you could have something called quadriceps tendonitis. Then if you kind of go down a little bit more, right in the middle part of the knee, right in the kneecap, we call that the patella. The patella rides right on top of this thigh bone called the femur, so we call that patella femoral syndrome. Below there, your patellar tendon, again, you can have patellar tendonitis, or even like in the lot younger patients who tend to have that pain, that little bump at the bottom part of their kneecap. It's called Osgood disease, or that's just irritation of what we call this tibial tubercle. But a lot of these are treated very similarly, and I think this joint is so bothersome for so many people because it's a very mobile joint. So I mean, if you compare the patellofemoral joint to like your hip joint is a ball in a socket. It's a very constrained joint just based on the way that the bones are made up. But your kneecap, if you're sitting there and your leg's completely straight, you try to move your kneecap back and forth, you notice there's a lot of mobility of your kneecap. So your kneecap relies on a lot of what we would call dynamic stabilizers. So muscle components from your core to your hips, your glutes. Again, this is stuff that I'm sure Alex would talk a lot about. Quadriceps muscles, not only the muscle strength, but also different types of mobility and things like that. So if people have like really tight hamstrings or really tight IT band, that all of that can come into play in regards to developing any various form of patellofemoral syndrome or, anterior knee pain. But again, a lot of these are treated non-operatively. There's really not great surgical management even for this. I mean, if you had really bad cartilage injuries, there are things we can do, like in very extreme cases, but for the most part, this is a non-operative issue that gets better. Sometimes it can take 6 to 8 weeks of physical therapy, but I would say, again, like if there's one thing that you could take away from this is that this type of issue, so again, like pain going up and down stairs, squatting, lunging, sitting down for a while, all of this stuff is very normal, and you see this a lot of the time in runners. Just they've gotten into something new, and for whatever reason that becomes painful. And again, physical therapy can be very, very helpful for this. The other issue that we see around the knee is something called a IT band syndrome. So your IT band is a very thick structure that starts basically right on your iliac crest and runs all the way down and attaches right onto the outside part of your shin bone. But again, like sometimes people will present complaining of just this, again, vague sort of knee pain on the outside part of their knee that usually is a lot worse with running. And again, there's a lot of things that come into play here, a lot of muscular things in regards to there's different forms of weakness around the hip, different forms of weakness around the knee that can cause this. But again, I would say 99.9% of the time, this is something that's managed non-operatively. In the very extreme cases, you can do these things where you try to actually lengthen with surgery the IT band. But again, like pain that starts on the outside part of the knee is a very common reason why people come in there, and they actually call this runner's knee. So the IT friction band syndrome, where the IT band is just very tight and it's just rubbing right against the outside part of the knee. But again, like I said, another thing that's treated very well with physical therapy. There are a lot of people who also come in with pain wrapping around the back part of the knee. And usually pain in the knee joint itself doesn't present as pain in the back part of the knee. So again, you start thinking about, what runs in the back part of the knee. There's the hamstrings run, again, if you're sitting there with your knees bent, you can actually feel these two structures on the side, on the outside part of the knee and the inside, like they basically feel like ropes back there. And those are your hamstring tendons. You have hamstrings on the outside part of the knee, you have them on the inside part of the knee. But these can be very bothersome for people. They'll come in, they'll have this, this cramping in the back part of their leg. And again, you can have hamstring tendonitis anywhere along the whole length of your hamstrings, which the hamstrings, they start up basically on the bone that you sit on, and they run all the way down past your knee. But again, people will come in, they'll have some pain with sitting down for a while, they'll have pain with running, usually located in the back part of the knee. The other thing I didn't mention was you also have calf muscles that come and they insert on the back part of the knee too, so you can have like a tendonitis of your calf muscles as well. You have hamstrings on the inside part of your knee that they're called your pes anserines. So I believe pes anserine translated actually means like chicken foot, because you have these three tendons of your hamstrings that wrap around the inside part of your knee, and they insert right over here on the medial part of your knee. So honestly, if you actually feel very closely, like right below your knee, you can feel like these little tiny tendons that are below there, and these are your pes tendons or your hamstring tendons. So again, there's a lot of various structures that are in very close proximity to your knee joint, the knee joint itself, that can cause pain that are not actually coming from the knee joint. If you when people think about knee pain, they think about the meniscus that's located like right in this area, or like a cartilage. But just right below there, again, this is your pes. So that can kind of masquerade a little bit as knee pain or like meniscus tears or arthritis or things like that. But usually that's something that, again, physical therapy can be fantastic for that. Sometimes we can do steroid injections into those areas, but again, there's various spots on the knee where you can have tendonitis, primarily from these hamstring tendons. Meniscus tears are a little bit less common in runners. I would say the typical pattern for a meniscus tear, or like an acute meniscus tear or an injury, is when you have like some type of twisting injury. And that will cause pain basically directly over top of the joint line. So if you were to, again, you're feeling on your knee trying to think about where this stuff is hurting, right below your kneecap you'll feel like kind of the soft spots around there. So if you have pain around in there on the inside or the outside part of the knee, it may be a meniscus tear, but again, like that's a little bit less common in runners. That's not a typical injury that we see from overuse is developing these meniscus tears. Now, I mean, meniscus tears come in various, shapes and sizes. So there are tears that happen from an acute injury, but there are also meniscus tears that take place over a long period of time, where we call these degenerative meniscus tears. The meniscus tears could kind of be similar to like a hangnail, for lack of a better term or lack of a better analogy, because the blood supply to the meniscus is actually very poor. So this is like, imagine we're looking at the inside part of the knee here. In the middle part of the knee, you have your ACL. These are ligaments that attach your meniscus to your ACL. But all the blood supply from the meniscus basically comes from the outside and goes right to the periphery of the meniscus. But whenever there's not very poor blood supply to this inner rim of the meniscus right here. So again, over time, you can get these degenerative meniscus tears, and sometimes we don't have to do anything for those. Same way with like a hangnail. So I mean, again, like how you have some hangnails that you have them, but you don't even really know them until you look down and they don't cause any pain. But you have other ones that for whatever reason they hurt really badly, and you have to just trim off that piece of hangnail. Meniscus is very similar. So I mean, usually the first line treatment, if it's a kind of degenerative meniscus tear, is again steroid injections, physical therapy. The ones that have like a big flap of meniscus that kind of flips inside of the knee joint and it's causing mechanical symptoms or catching and locking, those are the ones that typically require surgery. But again, these are not things that typically happen with running. Now, if someone were to sustain a fall or something like that while they're running, then again, that's a different story. But for the most part, just gradual straight line running is not something that you would have to be too concerned about this. Arthritis is another thing that people get concerned about in regards to their knee. They're always wondering, like, what do my x-rays look like? Do I need a knee replacement? Can I keep running? And again, like that's why we usually get x-rays in everybody to see. I mean, because you can develop arthritis at a young age and just sometimes there's a hereditary component to it. And also if you've done a lot of things where you have a lot of impact on your knees, then you are a little bit higher risk for developing arthritis at a younger age. There are things that are, again, there's no way to cure arthritis right now. So I mean, like, a lot of the times we manage a lot of the symptoms. I would say this is these are extreme examples of what people come in with bad knee pain. But again, there are certain things we can do in patients who are a lot more active, and these are two examples of them. So the first one on the left side is a partial knee replacement. So with a partial knee replacement, you're really only replacing the affected part of the knee. So again, like this is the inside part of the knee, this is the outside part of the knee. It's like we're looking at the knee head on. And the arthritis is basically isolated to this inside part of the knee. So now we can replace just that inside part, and you're keeping a lot of the ligaments in there. You're not replacing the parts of the knee that are still good, like the outside part of the knee or the kneecap joint. And again, patients can still run on these. So if you were an active runner before, I mean, you could theoretically still run on this. The risk would just be that you would potentially wear out these components a little bit sooner, and you need this converted to a full knee replacement. The other option is this diagram over here. So this is what we would call an osteotomy, or basically you cut the bone. So you can see there's a cut that was made right here in the bone, and bone graft was put in there, and then it was fixed in place with this plate and screws. But it basically just changes the alignment of the knee to make it so that there's less stress actually going through this inside part of the knee. So you're not necessarily addressing the arthritis per se in this one, but as you change the overall alignment, you're changing the amount of force that's going through that inside part of the knee. Again, prior to even undergoing any of this kind of stuff, even if someone came in with this amount of arthritis, you can still do steroid injections, and there's other injections like these, they're called hyaluronic acid or gel types of injection. A lot of these things can really be very helpful in regards to treating arthritis, but this is, again, I would say a little bit less common in regards to the people who come in for pain just after they've been training for a certain race. Another thing we see quite frequently, though, is a stress fracture. So the story for this would be someone who isn't much of a runner usually, and they decided their goal for the year is, or New Year's resolution is, they want to run the Flying Pig Marathon, and all of a sudden they started to get into running. They've either haven't ever ran before, and then they start getting into this and they're running a lot, or someone who has been a couple mile a week and then all of a sudden really ramp things up, and you can develop, again, a stress fracture. And what we're looking at here are these are MRI images of a knee. So these are different imaging sequences, but on this sequence of MRI, the bone should be, I'm not sure how well this is, you guys are able to see this, but the bone should be this nice dark color. This white right here is the stress fracture, okay? This is all swelling. So on this sequence of MRI, fluid usually lights up white. So this is all fluid in the bone or swelling in the bone. On this sequence of MRI, the bone should be white like this, but you're seeing this kind of little crack right here. Again, this is a stress fracture in the top part of the shin bone. In comparison, this is a MRI of a different knee. This is like we're looking head on at the knee, okay? This is the inside, this is the outside, and this is a side view where this is the front, this is the back, thigh bone, shin bone, and again, this normal bone should be dark. All this white is a stress fracture, but these are really hard to treat, to be honest with you, because patients are very upset when you tell them they have a stress fracture. Because the only way you can really treat this is with taking the weight off there or relieve the inciting event. So again, usually it's crutches or some form of non-weight bearing, and sometimes these can take about 6 weeks. So again, honestly, these are one of my least favorite diagnoses because honestly, the patients they're almost devastated when you tell them they have a stress fracture. So again, that's why whenever people have any injury, I'm always like, okay, just gradually get back into it, because this could develop in anybody. So someone who has any type of injury, and then all of a sudden they're out for 6 weeks doing rehab somehow, and they want to get back into running, and it's a tough injury to recover from, or not recover, but just to be diagnosed with. So that's really all the topics that I was going to go over. I figured if anybody had any questions about Tiger Woods, I could answer those as well, or if anybody has any questions about, again, there are certain events that take place. I remember when Tua Tagovailoa, the quarterback for Alabama, dislocated his hip. I got a lot of questions about that. I've got my neighbors have been stopping me and asking me about Tiger Woods. So anyway, what questions can I answer for you guys about the knee, or honestly, if it's about Tiger Woods, I'll answer that too. Yeah.
Yeah. So if you have, let's say you're running and you start getting pain in the exterior side of your knee, and maybe it's because of your IT band, should you stop running? Should you break and walk to the sides and restart running? What should you do?
I would. It's like that old joke you hear where when you go to the doctor and they say, hey, I hurt something when I do this, and the doctor says, well, stop doing that. It's really somewhat true. I think that our bodies are fantastic about determining what you can and what you cannot do. Even in regards to some certain post-op protocols, we'll be okay, you should be off non-weight bearing for so long, and the patient's well, it doesn't hurt when I do this, and it's usually fine. So I would say there's a lot of modification that can be done in regards to stuff. So I would, if you're doing a certain thing, before you can get to a physician or before you can get to a physical therapist to actually treat that condition that's going on, just try to modify your activity. So again, if you're running and every time you run you're having a lot of, again, if you think it's IT band syndrome or tendonitis or patella femoral syndrome, I would just stop doing that. See if there's other things you can do, like a lower impact exercise, like a elliptical or cycling or swimming, something where you can keep your cardiovascular health up, but at the same time you're not causing that sort of discomfort.
I have a question. So for people that are younger that have arthritis, and it's not as bad as those pictures, what is your first line of attack with them?
It depends. It's a somewhat complicated topic, I'll be honest. So there's arthritis, which is just the overall generalized disease of the cartilage, okay? Or you can have these very focal cartilage defects, and the treatments for those would be very different. So I would say most younger people do have a focal cartilage defects, and sometimes that treatment actually does become more surgical in nature, again, if it's a very focal defect, so that it doesn't turn into a whole disease of the entire knee joint, and then you're looking at a replacement type of surgery. Once you already have that diagnosis of arthritis, you're looking at there's no salvaging this cartilage, there's no cartilage restoration surgery that can be done. And then again, you start talking. I think the first line is always going to be non-operative, because again, there are people, just because someone has a terrible looking X-ray where it looks like they have bone-on-bone arthritis, and they need it. Most people will be oh yeah, that a knee replacement would be appropriate. So there's people who don't have a whole lot of pain with those types of imaging. So I think again, steroid injection, physical therapy, all of that stuff, just anti-inflammatories, you can do and then also talking about activity modification. So again, everybody's here. if you're a runner, it's tough. If that's like the thing like that you're very passionate about, that's always a tough conversation to have. But I mean, again, if there's other things that you can do in regard to stay healthy and stay active, that's an acceptable alternative to you, then that's an option as well.
What about, so for IT band and that kind of stuff, is that something that is kind of can be a chronic thing? So I had, like 4 or 5 years ago, I was diagnosed with that. I stopped running, did physical therapy, everything got better, went back into running, and then it seems like and someone told me, they're like, oh, well, you're going to have that for the rest of your life if you have that. Is it?
I don't think so. I don't think that's necessarily the case. I think that, that you can definitely have flare. I mean, my assumption would be there's something about, well, let me back up for a second. You develop like your gait, your running pattern throughout your entire life. So and then you develop this for there's some reason or something that happened to cause you to have pain in this area. And you go to physical therapy, and I think it partially gets resolved. But I think that again, your rest of your life, you're still trying to overcome whatever that issue is that causes you to have that. I think you're more prone to have that in the future. I wouldn't say at all that you're absolutely going to have it forever. I think you'd probably be at higher risk just because, again, there's for some reason that happened in the first place. But I think that again, if you did physical therapy in the past and it went away, my assumption would be, honestly, if you do physical therapy again, even though it seems like it'd probably be frustrating, like, if I did this once, I don't want to go back, that it would still be worthwhile to try it again.
If you have healthy knees, what are the top 2 or 3 things you can do to keep them healthy?
Probably the one thing is weight. So again, like your knees see probably 4 to 5 times your body weight whenever with any sort of activity, and you can see up to 8 times your body weight going up and down stairs, running up and down hills. So again, very subtle changes in your weight can cause a significant benefit or detriment to your knees. We're talking 5 pounds. So again, like keeping a healthy weight, I think is very important for your knee health. Staying active, again, I think is your overall cardiovascular health can contribute to your knee health as well. Just taking the time to warm up. I mean, things that are very general or basic. Everybody stretch before you run. I think those are probably the biggest things. Again, don't get into things too quickly where you're going to be at risk of developing a stress fracture or something like that. And also, I think staying in your comfort zone as well too. I think people can get into trouble whenever they basically try to get into things too quickly. So they've been running for a long time, then all of a sudden they want to get into some very sort of high dynamic type of exercise. Like those could be dangerous for your knees or the rest of your joints as well. So just taking a smart approach to exercising.
What about just leg strength? Hamstrings versus quads versus calves?
I'll let Alex talk about that. You want to answer? What's your thoughts on that?
You never go wrong getting strong. So generally, quad strength is going to be protective, hamstring strength is going to be protective, but even when we look at hip strengthening, hip control, ankle strengthening, all of these and staying active, like Dr. Burleson said, are some of the best things that we can do in the long term to help prevent further arthritis and to also just kind of facilitate more movement in the future. Other things you can do, like sleep, is probably a factor. Anything that's going to reduce systemic inflammation probably has some positive effect on arthritis in the long term, right? So sleep, your diet can probably have some effect, and decreasing overall stresses in your life as much as possible, right? All of these things can have positive effects in the long term of sensitivity sensitivity related to arthritis. Because like Dr. Burleson said, there's some times in which we see on imaging where people would have maybe mild or moderate or severe arthritis in the knee, but someone with severe arthritis may not have the same level of pain that someone with mild arthritis might have. So everybody's a little bit different, and everybody has different thresholds. I like to use the analogy of like a pitcher of water. There's a lot of different things that can contribute water to the pitcher, but it's only when the pitcher overflows is really when we have a pain response. So you can contribute and you can reduce any of those factors that contribute water to the pitcher. So your sleep, your stress, your activity level, your strength, all of those, right? Or you can simply just try to make the pitcher bigger, right? All of those factors can help reduce pain and help you to increase your healthy lifestyle in the long term.
Last question, what about supplements like glucose?
There's no literature that says that stuff works. I have seen enough patients who take them and they say they work that if someone says I've been taking this and this joint health pill and my knees feel fantastic, I would never tell them not to take it. But I mean, again, like the randomized controlled trials they've done in regards looking at that doesn't say that they work, and they're not cheap. So I don't typically recommend them. But again, like if someone's taking them and they seem to be working, I wouldn't tell them not to take them.
No other supplements that you're aware of?
Not really, no. In regards to joint health, no.
Is that the same for collagen too, since that's like the big thing for joints now, there's not really any?
Correct, yeah.
It's probably not specific enough when you take it orally, you know?
Yeah.
Like, who's to say it's going to get to where it probably needs to go?
I mean, there's a lot of things that we develop now. I mean, there's a lot of different types of injections. There you have steroid injections, or if you've ever heard like hyaluronic acid injections, PRP, which is platelet-rich plasma, where you take your blood, spin it down, stem cells. Again, we have all these different things, but the only thing that all those have in common is they decrease inflammation in the knee or in the joints, and so that's what helps out with the pain. So again, however you decrease inflammation, whether it's pills, injections, supplements, sleep. I mean, that again, like that's the only thing is decreasing the amount of inflammation.
I have a question. So I started running about a few years ago, and this doesn't happen all the time, but I'm starting to get, like my right knee gets swollen, and I don't know, and so I'll stop. Like it'll get swollen after like 15, 20 minutes of running. It's like starting to freak me out, kind of. So I stopped. Like I'll stop and then I'll try to get back into it. I'll walk and then I'll try to get back into running, and then it starts to hurt. It doesn't do it every time, but when I get to a certain speed or a certain pace, it starts to get swollen. So I'll go home and I'll put ice on it, and then after a few hours, it'll go down. Should I be concerned?
Not necessarily. I wouldn't say it's normal.
Yeah.
But I mean, I don't. But again, like the concern level, I think that my assumption would be honestly that is you probably have some type of patellofemoral syndrome or some the generic anterior knee pain, because that can cause swelling in the knee. Absolutely. You're not whenever again, like we talked about, your kneecap is typically is designed to glide right in the middle of your thigh bone. If you have any sort of alterations in the muscle makeup, your flexibility, that kneecap contract. All it takes is 1 millimeter. So again, like imagine like the width of a pencil breath, or like the tip of a pencil, one way or the other, and all of a sudden it's seeing more pressure. That increased pressure is just causing pain. It's not necessarily wearing down the cartilage or causing arthritis, but it's causing pain, and it can lead to an inflammatory response. So again, I mean, I don't think it's something that you need to be concerned about in regards to like a potential surgical thing, but it is something that I think probably could be corrected.
Okay. Do you think shoes make a big difference in running?
If it potentially could alter the way you run, it could alter your gait. I mean, yes, because again, like that's all it takes is again, like I said, we're talking in regards to like your kneecap joint, we're talking a millimeter. So if you do something where all of a sudden you're swinging your hips a little bit differently, if the weight's a little bit different of the shoe, the way your heel strike is different, I mean, all of that stuff could cause your running gait to be a little bit different. So I mean, it potentially could. I wouldn't necessarily always blame it on the shoes, but I mean, it could absolutely contribute.
That's when I know to change my shoes when I get a little bit of pain.
Yeah. All right, we could have Alex come up here then. I say if you don't want to, I have a podcast. It's called the Sports Medicine Orthopod. So if anybody does want to hear about Tiger Woods, we did a podcast last night talking about that.
Did he have like open compound fractures?
He had a segmental open tibia fracture.
Okay.
He had a talus extrusion of his talus, so basically the ankle bone basically popped out of the skin, and he had an open Lisfranc injury as well.
I heard it was his foot, I just didn't know what parts.
So it's also this one should be able to go to the next slide right there.
Okay, this one goes to the next one, this one's the high, or the pointer?
Yeah.
Okay, cool. All right, I'm Dr. Alex Contner, just call me Alex. So we're going to talk a little bit about the knee. Hopefully we're just going to build upon Dr. Burleson's presentation and talk about some of the different rehab stuff. Hopefully some of the questions that have been answered we'll touch again on in this presentation, and some of the rehab components and the variables and how we change things. And then I'm happy to take some questions at the end as well. So like Dr. Burleson said, there's a lot of different presentations of knee pain, all right? I won't bore you guys by going through all that stuff again, but a lot of times we lump them into these gradual onset and more acute knee injuries. Acute knee injuries are probably more those red flag injuries that you probably don't come directly to us for. Those are ones that you're going to go to Dr. Burleson's office, have him evaluate you, and then if he doesn't see anything that's concerning, get over to PT. But a lot of these more degenerated or overuse injuries, right? I put in quotations overuse because it may not be overuse. When we think about the tendons and the structures in the knee, it really depends on what we have the capacity, what load capacity we have, right? So if we do too much too quickly on the body, it's going to get sensitive and irritated, and it's going to cause pain, or it can cause some damage depending on if you continue to do it. But when we think about overuse, and it's funny, in rehab, a lot of times we are actually going to load the tissues and try to strengthen the tissues that are being overused, and we're going to make them more resilient to that by thus strengthening them more and using them more. So it's kind of a catch-22. So we're trying to make the body more resilient to those type of things. So meniscus tears, they can be gradual, and that's what we see most commonly is we see joint pain. Sometimes it's more nonspecific. A lot of times it's more on the medial joint, especially with runners. They tend to have more pain kind of on the inside of the knee joint here. And a lot of times they're not acute, so there was no one instance in which they twisted and turned or stepped off a curb weird and they felt a pop. And a lot of times we don't get the catching and popping with these either. So the more degenerative meniscus tears, we tend to say those are really rehabbed very, very well in physical therapy, and they tend to have very similar outcomes to those being operated on from a meniscus tear standpoint. But once again, it also depends on what the mechanism was and where the tear was and how extensive that injury is. But usually the first line of care is to either do kind of an injection and get to PT, and then if it doesn't resolve in PT, that's when we send you back to the doctor, and they'd probably consider surgery at that point. So, all right, so when we talk about running, I think one of the most important things that we can talk about is all of these injuries the pains that we're having that are overuse, right? I think it has more to do with our body just really hasn't adapted to the loads and stresses that we are trying to do. So there's a lot of different variables in play when we have pain. And especially with running, there's a ton of different variables. Most often I see people start to have pain after they do too much too quick, or they change too many variables too quickly and their body has not had time to adapt. So they're pushing more and they're pushing past some of the protection mechanisms of their body. And I think that's when you start to see more of this quote unquote wear and tear of the joint, is when you've gone beyond the level in which your body can adequately protect you. Okay? So when we think about arthritis, I think this is a good time to talk about this. When we think about arthritis, we used to think of it as like completely wear and tear condition, in which we used to think runners were going to have way more arthritis because they're going out and they're using their knees and they're doing a lot more weight bearing through the knees all the time. Well, really research doesn't actually support and doesn't actually say that there's any difference between those running and not. It tends to be runners actually have more healthy knees and have less arthritis. So we don't want to automatically assume that arthritis is a wear and tear condition. But when we think about the runners that do develop it, it tends to be that their training protocol is probably not appropriate. They're probably not recovering. They have nutritional deficit, or they're doing too much too quick to the point where their body can't adapt and handle that load. So when we think about the different variables, all right, treadmill is going to be different than road running. Treadmill requires a little bit more control of your foot because it's more cushy, decreases the impact forces, which is nice because it can decrease kind of how quickly we load the leg and the knee, but at the same time, more softness and more time requires a lot more control in the hip. So I will get people that come in that are road runners all the time, and then they'll go to Orange Theory Fitness and they'll start doing a lot more treadmill running, which their body hasn't really adapted to that type of control that's needed in the hip and the ankle and the leg, and they're doing a lot of volume or maybe going at a different speed, and they're adjusting inclines. you're just changing so many variables that a lot of times the nervous system will kind of protect the knee, will give you tightness after, or can give you pain if you're pushing it too much. So those are times in which we need to take a step back. We need to deload a little bit, right? We don't want to give the body more than it has the capacity to do. So it's very easy to take any of these variables. So incline and elevation, speed, so cadence, that's how quickly we step per minute. And then our distance, shoes and orthotics was mentioned, right? Shoes change the variable. If you go to a flat shoe from a very high elevated heel shoe, it's going to change the way you run. Your body, if you're completely changing the way you're running, your body is not adapted to that way of running. So if you do change shoes from, a flat to a high or a high to a flat, then you're probably going to want to kind of take it easy and deload and build that up again, because it is going to change the way you run to a certain degree, just like treadmill versus the road. I think the easiest thing, so when people start to have pain, and this kind of, Banks, and I believe is your question, when people start to have a little bit of pain, one of the easiest things that I can tell people to do is it's very difficult to change people's gaits, and and I don't like to do that as a therapist right away. It will be something that we look at long term if some of the initial modifications and some of the strengthening stuff that we're doing doesn't make any effect. But I actually like to look at our cadence first, okay? So the simple cue I give people, shorter, quicker steps. Shorter, quicker steps usually decreases some of the impact forces on the front of the knee, and it also just decreases the overall impact and push off, so less forces. So that's a cue I give, and then most commonly I give people is try to not hear yourself landing as much, okay? So a lot of times you'll hear people and they'll be very, very heavy on their feet, loud impact forces. The louder it is, the more force coming through the foot, and the more your body has to distribute. So try to cue people to be a little bit kind of quieter on their feet, which tends to kind of accentuate the load over a longer period. Once again, that requires a little bit more control in the hips. So all these things kind of depend on the person, but they're very good ways for our body to disassociate the pain with that movement, because it changes the movement enough that your body is not sensitive to it. Hopefully that makes sense. We can talk more about it if anybody has questions. All right. So other running considerations. I think one of the single most important things that people should do that probably is not done that much is a cross-training program. A lot of runners like to run because that's what they like to do. A lot of runners do not like to do a strength program. So I think there's a happy medium here. I like a 10 to 15 minute routine, and that's really all it can take. You can do more than that, you can do less than that, but 10 to 15 minutes, 2 to 3 times a week of strength training. All right, it's different fiber type, but it's going to help give your nervous system more protection. The muscle systems in the knee and the joints themselves will be more protected when there's more muscle strength there. It's also a different kind of load, so it makes your body more adaptable to stresses. So I think generally if people can add a cross-training program, and we'll go through a couple of exercises I would maybe put into that piece that are pretty easy to do, that would be a huge value, I think, for most people. As Dr. Burleson mentioned, I think a warm-up can be valuable. I really like a dynamic warm-up. I don't particularly love a lot of static stretching, but if it feels good to you, and there's no problem with that. Some of the research is not necessarily concrete on it actually helping or preventing injuries. So if it feels good to you, you can do it, but there is maybe a little bit of evidence that says a dynamic warm-up can help. So some guidelines for progressing running, right? So often we're training for the pig, and my mileage goes from 4 miles a week or 5 miles a week to 20 miles a week. I like to give people pretty simple guidelines for progressing running. If you have any symptoms during your running, you cannot progress, okay? You need to find what you have the tolerance to do and don't progress past that too quickly. When people are training, a lot of times, people will add more distance at the same time that they're going to add hill sprints or they're going to change their speed. My general guideline is try to only change one variable when you're running. So if you're going to increase your speed, don't also increase your distance. If we're going to add a lot more inclines and hills, once again, don't increase your speed or your incline, right? So add one variable at a time and the maximum 2, and slowly build up. If you have any symptoms during or after, that means you can't progress and you can't increase those variables because your body has not sufficiently adapted to that level, so don't push it up. So for general rehab and just knee pain in general, not all knee pain means that you're doing damage. That doesn't mean that it's a good idea to always poke the bear and continue to attack it, right? We don't want our body and our brain to associate these movements with pain all the time. But a little bit of pain that doesn't really get any worse after you're doing something and it doesn't last, like going up and down the stairs, if it's a little bit painful, probably not the end of the world. If you're not noticing swelling after, that's another good indicator. So I like the quote, poke the bear but don't attack it. So we're trying to build the resiliency of the body, and if we can do things and we can modify to make them pain-free, it's usually a good thing. Our brain will associate the movement without pain again, thus we can kind of get back into normal activities. So I liked, once again, slowly increasing intensity of a program is very important. All right, from a cross-training perspective, I talked about like 2 to 3 times a week is typically what I like. I like to do it on my off days from running, but you can do it on your run days too. I don't mind a couple exercises before we run. I sometimes tell people if you want to go do a couple of your exercises and kind of prime those muscles to work, that's fine with me. You don't want to completely fatigue them, right? We want to build and maintain some of that threshold, so you don't want to completely fatigue your muscles to the point where they won't be able to protect you as much during your run. But I really like hip and ankle control and balance exercises. They can all be valuable. They all help control our leg when we strike and when we're doing running. So adding some of those can make you more resilient on the road. Heavier strength exercises like squats and deadlifts, if you can do them safely and you've been trained to do them, there's no evidence that says those are going to be harmful in the long term, and actually there's some evidence that supports the use of those in the long term. Once again, very, very strict guidelines. Like if you're getting pain during or after, we need to modify to make that not painful. If you have difficulty with that, come to a physical therapist, we can help you with that. Or we can modify, right? Or we can make sure that we build up some of the other strength and tolerance control to get you into those activities if it's a goal in the long term. I'm not saying that everybody needs to squat and deadlift. I don't feel that at all. There's a lot of different ways to skin a cat, but you know yourself as if that's something that's going to keep you motivated and in the gym and active in the long term, then I want you to be able to have the capacity to do that. So when we look at squatting and deadlift, can be helpful, can help build the strength, power, and endurance, but we need to find a level that is really suitable for your comfort. So I just did a couple quick examples going from more less difficult to more difficult. Less difficult, just holding on to a countertop. You can just do a mini squat back to whatever depth you feel like you can tolerate without really any pain or discomfort. Then I like to do the Swiss ball on the wall or medicine ball on the wall, and then you can kind of lean on it. You can drop the butt down, once again, as far as you can. This is going to put a little bit more stress on the front of the knee and the kneecap, but it eventually can help to tolerate that to getting into more of a, this is a goblet squat on the right, and there's millions of different variations of all of these, but in the long term, we're just slowly increasing intensity using those same guidelines. Don't want to increase pain really after. We don't want any swelling after. We want to be able to do an activity that the body likes. The more activity, I think motion is lotion. So the more motion we can do, the better. So a couple example exercises, and these are nice cross-training exercises. I really went with those for our exercise examples. I really like a lateral walk with the Theraband. So there's multiple ways you can do this. I like different placements. So you can put it on the front of the feet here, and I kind of have people what's called externally rotate. So I have them rotate their feet out, which is going to get more hip involvement. You can get the same thing here at the legs. You get a little bit less hips, and you're going to get a little bit more quads. And then you can actually move the band all the way up to the knee too. So a lot of people are going to ask me, well, which one's best? I think there's warranted reason to do all of them, right? The more variations I think we can expose your body to, the more resiliency you're going to build in the long term. This monster walk is another one where it kind of carries over into running just a little bit. So we kind of take a deep squat and we go kind of forward and out. So we get a little bit wider base of support, but we're still progressing forward. So these really kind of work a little bit of the control, the balance aspects of the knee and the hip and the ankle. So it puts everything together, which I think is really valuable. A single leg deadlift is another really, really valuable thing, especially if people are having a lot of pain on impact with their running. Getting them into that kind of impact position where they would stand and taking them down and trying to just have them tap and come back up using their control and their balance. Once again, it's going to work quads, it's going to work some hamstrings if you're doing it right, it's going to work some glutes, external rotators of the hip. This is not a beginner exercise, this is a little bit more advanced. But there's multiple variations that you can do of this that are a little bit easier. And then I like a 4-way hip. So what's interesting about this exercise is, as you can see, she's standing on her left leg. In this exercise, it looks like we're doing all the work on the right, but I actually care more about the left foot. So in the left foot in this, she's doing all the work with her right, but it actually has to work her left hip and her left quad and hamstring and all the co-contraction muscles there to support her and to stay upright. So how we make this exercise actually a little bit more difficult is you can put something more unstable under her left foot. So you can put a balance foam board or something like that, or a Bosu ball, or you can do at home just like a folded towel or something like that. So all of those can be valuable. These are just a couple examples, but there's hundreds and hundreds of things that you can do. Some of the personal trainers here, I'm sure, could take you through a little bit of cross-training routine. But generally for me, it's strengthen and build endurance of the knee and the leg and the hip and the ankle in a way that is supportive to your body, not provocative, and that's going to just build resiliency and build adaptability. So if you have any questions, we are upstairs, and we'll be happy to kind of look at you. Once again, physical therapy now is kind of direct access, so if you do have trouble, you can come directly to us. And if we see anything that's concerning and we need to make sure that you get into see an ortho, we got Dr. Burleson that's great next door. So, any questions for me?
I got a question on squats.
Mm-hmm.
Knees in front of the knee, in front of the feet, or
Yeah. So,
I've heard.
good question. Exactly. So, I would say when we look at the research, it is not conclusive that one is better than the others. What we know is that there is natural variation in the way that people squat. And that is generally okay. So what is more important to me is, for whatever the way you squat, that we have great control coming from that, right? If your tendency is to squat and to have more of what's called a valgus movement of the knees, so the knees are coming in more, well, we want to probably make sure that we have better hip external rotator control and hip glute control, because that's what's going to help reduce our forces in here and protect us as we go into that. Otherwise, if you do too much volume too quickly, you can end up with degenerative meniscus tear or something like that, right? So it's not so much that the movement or any particular movement is bad, it's what can you control and what is your body designed to support. Because for example, we might want to try to decrease some stress on the inside of the knee so we can put you in a sumo squat. Well, that may give you other kinds of soreness too, because you've never done a sumo squat before. So we'd have to bump you up to that. So general strategy, you got to cause the body to adapt. You mentioned toes over the knees. Toes over the knees is thought to, yeah, sorry. When we think about that, we tend to think it would put a little bit more stress on the back of the kneecap, so it may contribute to the patellofemoral symptoms. Once again, the evidence is not conclusive, but generally what I tell people that, if it feels better to do that, then do that. I don't personally instruct my patients to watch that unless it's very, very obvious, right? I probably don't want them like way over, but I tend to tell them if you can see the front of your toes, you're probably fine, if it feels more comfortable to do that. If they have more sensitivity and they have more compression and compression type pain in the front of their kneecap, then I might put them in more of this hack squat type position that's meant to prevent the knees from coming more forward. So I don't know that there's any best way of doing things. Not letting the knees come forward over the toes is generally more tolerated, and people tend to have less pain with that. But someone that's healthy, probably it is not a bad way to squat like that, as long as your body has the capacity to protect you throughout it. Any other questions?
Is pain the only indicator for, like, so when I do squats, a lot of times my knees sound, like the crepitus sound
Mhm.
sounds horrible. But
Yeah.
It feels fine.
Yeah.
So like, is that the only time when you're like, oh, there's something wrong?
Yeah, some bendy people and more flexible people tend to have kind of like more audible knees. Generally, I tell people that it's not really an indicative of anything negative. They've done some research studies on does the crepitus itself, does it actually lead to more arthritis, or is the arthritis associated with more knee crepitus? And it's not been conclusive either. So the sound itself, I would tell people don't worry about. But if you have pain associated with the clicking and popping, that can be a problem. So that's when I would probably get evaluated. But if it's just a little noisy, that's probably fine. Do you have any opinion on that?
I would agree with that. I mean, joints pop and crack for various reasons, and as long as it's not hurting, I would try to not be too concerned about it. I mean, because the flip side is that there's really nothing to do. There's nothing to do about it. Like you can't go in there and find crazy. You would think that like there's something causing that noise, and why does it sound like sandpaper? But it's not like there's something very obvious that you can do about it. So unfortunately, there's not much to do.
Anything else? Okay. Thank you, guys.